the last lecture of this curriculum, and I hope it's going to be as useful as the previous ones and even more useful. So these are the items that I hope to cover: flows, pressures, resistances, shunts, stenotic and regurgitant valves, pressure volume loops, as well as some comments on the FFR and IFR and similar indices. So we start with a question: a 65-year-old woman with multivalvular heart disease and atrial fibrillation with rapid ventricular response. Femoral artery saturation is 96%, pulmonary artery saturation is 55%, thermodilution cardiac output is 5 liters per minute. Now, taking this information in consideration, what is the true cardiac output? Look at the word true. This means that the thermodilution here is not the appropriate method by which we measure the cardiac output, and we will detail on that. So what's the true cardiac output? Is it normal? Is it low? Is it high? Or you cannot tell. Actually, the answer that I'm looking for here is the cardiac output is low. And what's the reason for that? Thermodilution is a method to measure the cardiac output when the cardiac output is not very low. But the important point, you cannot use thermodilution in patients with tricuspid regurgitation. I will explain thermodilution very soon, but this is an important point. In patients with multivalvular diseases, which involve atrial fibrillation as well as tricuspid regurgitation in the large majority of cases, you cannot rely on thermodilution. So if you look into the pulmonary artery saturation, this is low. So if you get a mixed venous oxygen saturation that below 65, it means that the cardiac output is low. Usually the mixed oxygen saturation in the pulmonary artery is between 65 or 70 and 80%. If above 80, it's high cardiac output. Below 70, 65 is low cardiac output. So there is a discrepancy here between the pulmonary artery oxygen saturation and the thermodilution calculated cardiac output. By the way, we don't measure the cardiac output. We calculate the cardiac output. There is no method, even in experimental animals, with putting a magnetic probe around the root of the aorta, which is the most precise method. You still calculate the cardiac output. And you calculate the cardiac output by whatever method. It depends on fixed principle. Even the thermodilution depends on the fixed principle. The idea of the fixed principle is that if you have a continuous flow in a closed system with a marker that's being continuously added to the flow, then the flow, which is a surrogate of the cardiac output, equals the amount of the marker you are adding and the difference in concentration of the marker at two specific points. And I will detail on that and explain الألغاز اللي أنا بقولها دي هي, and I'm sure in a new generation consider this less. So Adolf Fick introduced this back in the end of the 19th century. Cardiac output equals, this is wrong, it's not myocardial oxygen consumption, it is total body oxygen consumption divided by the arteriovenous oxygen difference. And the arteriovenous oxygen difference is equivalent to the arterial oxygen content, not saturation, minus the venous oxygen content. And how we can calculate the content? We multiply the hemoglobin percent by what we call the oxygen capacity of the blood, which is the amount of oxygen taken by 1 milliliter of blood to saturate it to 100%. This is equivalent to 1.36 milliliters of oxygen multiplied by 10 to change the percent into liters, multiplied by the oxygen saturation. So it is the fixed principle is most accurate when we have conditions with low cardiac output and a steady state. So if you have a large difference between the arteriovenous oxygen content, that's the situation where the fixed principle applies to the best of its utilization. And despite that, we have an error of 10 to 15%. And the reason of this error is that we frequently use the assumed oxygen content, assumed oxygen consumption. The assumed oxygen consumption is equivalent to 125 milliliters of oxygen per square meter body surface area, or 3 milliliters of oxygen per kilogram body weight, either situation. It's very rare nowadays to use a Douglas pump or spectrophotometry to calculate the amount of oxygen content. There is no use of that. The echo is telling us a lot of this information. But you have to know this information because sometimes you need the cardiac cath, and I will allude to that. Now, here, the larger the denominator, which is the maqam, the more precise the calculation of the cardiac output with fixed principle. So the larger the arteriovenous oxygen difference, this means that we can apply the fixed principle. So in a patient with multivalvular disease, particularly with atrial fibrillation, then fixed principle is the appropriate method, not the thermodilution. So what about the thermodilution? The thermodilution method, we used to in the past to inject some dyes like Evans blue, endocyanine green, but now we use normal temperature saline. Previously we used cold saline, ice water, very cold saline to the degree of 3 or 4 degrees centigrade. But now we inject in the proximal port of the catheter normal saline, and then we estimate the change in the temperature of the saline at the tip of the catheter. So it's warming of saline which is responsible for the result. And then we apply the Stewart-Hamilton formula. The Stewart-Hamilton formula, you don't need to remember it, but it's the amount of the injectate multiplied by the change in the temperature of the injectate and divided by the curve which is described, or the change which describes the change in temperature versus time. But the computer calculates it for you. It's most accurate in high cardiac output state. The reason for that is that the distance between the proximal port where the injectate is being injected and thermistor at the tip is going to be very short. So you have to have a high cardiac output in order to get significant change in the temperature of the saline for the mixture of the blood and saline. So it's inaccurate in patients with tricuspid regurg where the forward flow is being interrupted by the backward direction of the tricuspid regurgitation and by variability in the cardiac cycles. And because of that, we got some form of variability which exceeds that of the fixed principle and varies between 15 and 20%. So it's the same idea, but you are using the marker in fixed principle as oxygen, and you are using the marker in thermodilution as a temperature of saline. So whatever method you are going to use for calculating the cardiac output, it's the same. You are using the fixed principle, whether you. So if you look into this question. If you look into this question, the normal pulmonary oxygen saturation is somewhere between 70 and 80%. If it decreases below 65, it means that the blood has been stagnating in the peripheral circulation, so more oxygen has been absorbed from it, and by the time it reaches the pulmonary artery, it's low, and therefore the correct answer here is a low cardiac output, and the discrepancy between the pulmonary oxygen saturation and the thermodilution cardiac output because of the erroneous choice of the method by which we calculate the cardiac output. Now, obviously, we every day measure the cardiac output in the echo lab by multiplying the area with the velocity or the velocity time integral. So we calculate the area of the right ventricular outflow tract multiplied by the velocity time integral, and this gives you the flow again using the same principle that we alluded to. So we don't usually measure it in the cardiac cath lab, except very rarely. So let's move now on and describe some of the waveforms which we encounter in the cath lab. This is the pressure waveform in the right atrium. Similar waveform is encountered in the left atrium, but the mean left atrial pressure is usually higher than the right atrial pressure. And on the right side, the A wave is higher than the V wave, and the reverse is on the left side. And the reason for that is that the compliance of the left atrium is much more impaired than the right atrium, being insinuated between the heart anteriorly and the spine posteriorly. So as a result of that, the V wave is higher in the left atrium. Now, as you see here, we have an A wave, which follows the P wave. Sometimes it follows even the QRS complex, and then you have a V wave, and the V wave follows the trough of the T wave. Look at the rising limb of the T wave. It's completely different from the rising limb of the pulmonary artery. So you have to have a sloping upstroke here in order to make sure that you are in the wedge position. And you have an X attached to the A and a Y attached to the V. So usually, because of the much fluctuation with respiration, we resort to getting the mean pressure. Another reason we rely on the mean pressure rather than the fluctuating pressure is that the fluid-filled catheter is liable to various oscillations. So the reason most of the calculations that you are using pressures rely on the mean pressure is to avoid the oscillations resulting from the fluid filled catheter. If you are using a transducer tipped wire, transducer millar catheter, then you ought to use the individual waves. So for the sake of government work, we use the individual waves as well as the mean, but we use the calculations the mean much more often. Now, another question, what's the likely cause of this finding? Look at the right atrial pressure waveform, and is that a picture of restriction or constriction or tamponade or tricuspid regurg? If you look into this, there is an attenuated A wave and there is a CV wave inscription. So this is a monophasic wave, and this is very characteristic of tricuspid regurg with a rapid wide descent. Not every rapid wide descent is constrictive pericarditis. By far, the commonest cause of a rapid wide descent is tricuspid regurgitation. And in this condition, you get ventricularization of the right atrial pressure tracing. So this is not a tamponade. This is not a constriction or restriction. I will show you the pictures in the coming slides, which describe what findings you encounter in constriction and restriction, but this is tricuspid regurg. Now, this is the pulmonary capillary wedge tracing with the V wave inscribed. On the left, you get the much fluctuations in the respiratory effect on the different waveforms. So you cannot rely on such a graph to measure the V wave or the A wave. And that's why we take the mean pressure in most of these tracings. On the right, you have the respiratory changes. You get the higher changes with the end expiration, and we rely on end expiration in patients who are spontaneously ventilated. If you are on the ventilator, you rely on end inspiration. The reason for that is that at end expiration, the intrathoracic pressure is equivalent to the atmospheric pressure, so it's practically zero. So we take the measurements at end expiration, and usually in spontaneously breathing individuals, it is the highest wave. Now, if you look into this graph, you will find that the T wave is very high. So this is a giant T wave. The giant T wave, by definition, means that the height of the V wave is at least 10 millimeters of mercury higher than the mean atrial wave. So the question is that due to mitral regurg, VSD, or non-compliant left atrium, or all of the above? The correct answer is all of the above. So you can encounter V wave very prominent in mitral regurg. That's obviously known to every person. But remember that mitral regurg is not the only cause for a prominent V wave. You can get even the prominent V wave much more prominent than the A wave in mitral stenosis. Well, why is that? The V wave represents the atrial filling in diastole. So in systole, the atrial filling in systole. So it depends on the compliance of the left atrium. That's why you get here a non-compliant left atrium as a cause of a prominent V wave. If you get traumatic affection and fibrosis and mitral stenosis or an atrial fibrillation, you can get a prominent V wave. A recently described prominent V wave is in the non-compliant left atrial syndrome. The non-compliant left atrial syndrome is a condition which occurs after multiple radiofrequency ablations of the left atrium in patients with atrial fibrillation with recurrence after the first or second ablation. You end up with a fibrotic sac, non-compliant. The patient is in sinus rhythm, but still he is in left-sided heart failure because of the non-compliant left atrium generating a prominent or a giant V wave transmitted to the pulmonary circulation responsible for severe pulmonary congestive symptoms. So remember that a giant V wave is not an indication for mitral regurg alone. Obviously, if you are doing the mitral commissurotomy and you generate during the procedure a prominent V wave, then you have to exclude a mitral regurg as a first possibility. But increase the flow through a ventricular septal defect can generate the same findings. So remember, there is a differential diagnosis of prominent V wave, and the definition is that it's at least 10 millimeters of mercury more than the mean left pulmonary capillary wedge pressure. And this is the pressure tracing in the right atrium in patients with cardiac tamponade. There is an A wave fluctuations due to the fluid-filled catheter, but look at the Y descent. The Y descent is blunted. We know from the pericardial curriculum, which we explained before, that when the tricuspid valve opens, it finds the right ventricle compressed by the pericardial effusion. This is in contradistinction to the situation in constrictive pericarditis. When the tricuspid opens in constrictive pericarditis, the ventricle is ready for reception of the early diastolic filling of blood because there is no immediate constriction around the heart. So you can imagine the pericardial effusion that's generating a tamponade as if it is a tight band around the left ventricle. So immediately after opening the tricuspid valve, the right atrium is looking into a compressed right ventricle. So you don't get a prominent Y wave. So you get a prominent X, but no Y wave. This is, as I told you, is different from the situation in constrictive pericarditis, where you get the famous M or W-shaped contour of the right atrial pressure. The mean right atrial pressure is usually in the range of 15, 16, 17, or 18, usually not more than that, and you get a deep X and deep Y descent. And the reason for the deep Y descent is that the early diastolic filling is uninterrupted in constrictive pericarditis, in contradistinction to the situation in pericardial effusion. And you can see this from the next slide when you see the classic square root pattern. So this is a simultaneous recording of the left ventricular pressure waveform and the right ventricular in green, right ventricular pressure waveform. Look at early diastole. And during early diastole, there is a rapid filling, and in few milliseconds, the pressure in the right ventricle as well as in the left ventricle rises markedly, creating the famous square root sign. So this square root sign indicates a gross early diastolic filling of either ventricle, and then at the same time, because of the pressure of the thickened pericardium, it immediately produces a considerable rise. Usually, the right ventricular pressure in constrictive pericarditis doesn't exceed 50. If it exceeds 50, it's more in favor of restriction rather than constriction. And usually, the end diastolic pressure, which is the pressure immediately after the inscription of the P wave, or which is simultaneous with the inscription of the QRS complex, is usually about a third of the systolic pressure. And as you see here, the end diastolic pressure is almost superimposed on the right ventricle. Is almost superimposed on that of the left ventricle. A difference which is often less than 5 millimeters of mercury, in contradistinction to the situation with restriction or heart failure in general. So we explained that in the curriculum of pericarditis in details, but this is just a revision of what we previously indicated. And this is another feature of constrictive pericarditis, which is the systolic discordance. If you look into at the beginning of inspiration, the right ventricular venous return will increase. At the same time, the left ventricular venous return will decrease, because the gradient between the pulmonary veins and the left ventricular pressure is increasing. This is due to insulation of the heart from the intrathoracic pressure. We explained that previously in the curriculum of pericarditis. So if you look at the beginning of inspiration, the rise of the right ventricular pressure results in a peak of the right ventricular pressure, which is at the lowest level of the left ventricular pressure. So the left ventricular pressure is decreasing, the right ventricular pressure is increasing in patients with constrictive pericarditis, and even the area under the pressure curve is decreasing in the left ventricle with inspiration, increasing with inspiration at the same time. And this is again against what is occurring in patients with systolic concordance, which occurs in restrictive cardiomyopathy and some cases of constrictive pericarditis. This is a slow speed of the recording paper. And as you see here, as you take a deep breath, the left ventricular peak systolic pressure decreases, and in tandem, the right ventricular peak systolic pressure decreases at the same time. We explained that before, but this is a phenomena which is very, very specific, very, very sensitive for the differentiation between constrictive pericarditis and restrictive cardiomyopathy. And obviously, everyone knows the importance of this differentiation. So we change from that into the calculation of the resistance, and this is a variation from Ohm's law, which is V equals I multiplied by R. V stands for voltage, and I for the current intensity, and R is the resistance. So rearrangement of the Ohm's law results in resistance is equivalent to the delta pressure, or the pressure changes across the circuit, divided by the cardiac output. It's very important to realize this. So to calculate the systemic vascular resistance, it's equivalent to the mean arterial pressure minus the mean right atrial pressure divided by the cardiac output. And in order to get metric units, or the dyne second per centimeter to the power 5, you have to multiply by 80. If you wanted to get it in with unit, then you drop the 80. So the normal systemic vascular resistance varies between 700 and 1600 hybrid or metric units, and this is equivalent to 9 to 20 Wood units. And the pulmonary vascular resistance is the mean pulmonary artery pressure minus the mean pulmonary capillary pressure. As you see, we are taking the mean for the reasons that I just alluded to, and dividing by the cardiac output. And if you wanted to get it in metric units, you multiply by 80. The normal pulmonary vascular resistance varies between 1 and 2 Woods units, or 20 and 130 metric units. So the change between Wood unit and the metric units is just you multiply by 80 to get the metric units, divide by 80 to get the Wood unit. We frequently use the Wood units. Now, there is here a very easy question, the vascular resistance calculation. If you have the mean pulmonary artery, right atrial pressure of 10 millimeters of mercury, mean pulmonary artery pressure is 40 millimeters of mercury, mean pulmonary capillary wedge pressure 20, femoral artery 130 over 82, and cardiac output is 4. So how can you calculate what is the pulmonary vascular resistance in Wood unit? Obviously, is it you cannot calculate, or is it 250 or 5 or 30? So it's an easy thing. It's you want to calculate the pulmonary vascular resistance, then you subtract the 20, which is the pulmonary capillary wedge pressure, from 40, so that's equivalent to 20 divided by 4. So the correct answer is C, or 5. Very easy. Now we shift to the how to detect the shunts and how to calculate the shunts. Obviously, in modern medicine, we no longer count the shunt or measure the ratio between the pulmonary artery pressure and the pulmonary blood flow and systemic blood flow, because we know that now for the shunt to be significant, you ought to get a significant chamber enlargement. So if you get an atrial septal defect, you are just looking for a right atrial and or right ventricular dilatation. If that's present, then you know that on the long run, these patients are going to develop heart failure or atrial fibrillation or both. So that's why we use it as and the guidelines use it as an indication for closing the shunt, either interventionally or by surgery, according to the situation. But in borderline cases, sometimes we are resorting to calculate it. Remember that the oxygen saturation in the superior vena cava is usually less than in the inferior vena cava. The reason is obvious to everyone, that the renal blood flow is much more than the oxygen requirements of the kidneys. So as a result of that, oxygen extraction from the kidneys and consequently the inferior vena cava is less than in the superior vena cava. And as a result of that, you get an oxygen saturation in the inferior vena cava. In this case, as in most patients, higher than in the superior vena cava. Usually, we take samples from the superior vena cava and the inferior vena cava. Be careful that in the inferior vena cava, the azygous vein is flowing the blood against from the lower segment of the body, so by the erroneous elevation of the oxygen saturation in the lower part of the inferior vena cava. But a significant increase in oxygen saturation, and I will detail on what is meant by significant, occurs in patients with anomalous pulmonary venous return coming to the superior vena cava. So as a result of that, you get mixing in the right atrium, more mixing in the right ventricle, more mixing in the pulmonary artery. So if you look into this graph, you get an increase in the oxygen saturation in the right atrium, right ventricle, and the pulmonary artery. So if you look into the pulmonary artery and look into the combination of the superior and inferior vena cava, and I will explain what's meant by combination, you will find a significant difference, and a significant difference occurs at an atrial level, and it's clear here, it's drawn here as a big atrial septal defect. On the left side of the heart, obviously, the normal oxygen saturation should be equivalent in the left atrium, pulmonary veins, left ventricle, and the aorta down to its bifurcation, and it's usually about 95%. So a significant shunt is equivalent as a mean that you take more than one estimation, a mean jump from the vena cava saturation to the right atrium of equivalent or more than 7%, from the right atrium to the right ventricle 5% or more, from the right ventricle to the pulmonary artery 5% or more. Now, if there is no left to right shunt, then the mixed venous saturation should be equivalent to the pulmonary artery saturation. So if there is no left to right shunt, we take the pulmonary artery oxygen saturation as a mixed venous oxygen saturation. If there is a left to right shunt, mixed venous oxygen saturation will be the oxygen saturation in the chamber proximal to the shunt. So if you are talking about a patent ductus or aortic pulmonary window, the mixed oxygen saturation will be in the right ventricle. If you are talking about VSD, the mixed oxygen saturation will be in the right atrium. What about an atrial septal defect? Here there is you have to make a calculation. You have to give 3 times the weight for the superior vena cava and 1 time the weight for the inferior vena cava. And the reason for that is that the short circulation time to the upper segment of the body gets the blood goes rapidly from the superior vena cava territory, so you multiply it by 3. The inferior vena cava by 1 divided by 4. This is the mixed oxygen saturation in patients with an atrial shunt, whether we are talking about pulmonary anomalous pulmonary venous return or atrial septal defect to its various kinds. Normally, if there is no right to left shunt, then the pulmonary venous oxygen saturation will be equivalent to the systemic oxygen saturation. Obviously, if you have a right to left shunt, there will be down regulation of the oxygen saturation from the left atrium or the pulmonary veins down to the systemic arteries. So shunt calculation depends on the ratio of the total pulmonary blood flow to the total systemic blood flow. So actually we use the fixed principle to calculate the pulmonary blood flow, oxygen consumption divided by the arteriovenous oxygen difference across the lung, and that's QP, divided by the oxygen saturation, oxygen consumption divided by the arteriovenous oxygen content difference in the systemic circulation, and that's QS. So that's it. You calculate the difference, you calculate the ratio by calculating the flow using the same principles that we alluded to in calculating the cardiac output in general using the fixed principle. So the pulmonary blood flow is oxygen consumption divided by the difference between the pulmonary venous oxygen saturation across the pulmonary circulation, and the systemic oxygen systemic flow is equivalent to the oxygen consumption, which is usually assumed oxygen consumption, as I detailed before, divided by the femoral artery or the systemic arteriovenous oxygen saturation. And if you solve the equation, then it turns out that the QP is equivalent to the systemic oxygen saturation in the numerator, because it was here in the denominator, the femoral artery oxygen saturation minus the mixed venous oxygen saturation divided by the pulmonary venous flow, which is pulmonary blood flow, which is the pulmonary venous oxygen saturation minus the pulmonary artery oxygen saturation. So in the previous figures, in the previous diagram that I showed, this was the measurements here, and it turned out if you substitute these figures into the equation, it turns out that the shunt is more than 3.5 to 1. Anything more than 1.5 to 1 is significant. The mixed oxygen saturation in patients with atrial septal defect, as I told you, multiply 3 by the superior vena cava oxygen saturation plus 1 by the inferior vena cava oxygen saturation, and you divide by 4, so you get 70, and 70 is used here for the mixed venous oxygen saturation in the systemic circulation. So we subtract from 95, which is the oxygen saturation in the femoral artery, minus 70, and then femoral artery oxygen saturation, which is equivalent to the pulmonary venous oxygen saturation, minus 88, which is the pulmonary artery oxygen saturation, and this was the result. So it's very simple. We don't usually calculate that because we know that there is some errors in doing that, so we depend essentially on the size of the right side of the heart in patients with atrial shunts, on the left side of the heart in patients with left ventricular shunts, or symptoms. But in borderline cases, you ought to calculate these shunts. Obviously, everyone is asking what's the role of cardiac catheterization in congenital heart disease. There is still a huge role of cardiac catheterization in congenital heart disease. In any intervention will include cardiac catheterization. In patients in which you want to remove the pulmonary vascular resistance, you have to have cardiac catheterization. In patients that you need a cardiac biopsy because of cardiomyopathy and myocarditis, you need to have cardiac catheterization. And in patients in which the resolving power of the non-invasive studies, like in imaging MAPCAS, major aortopulmonary collaterals, you need cardiac catheterizations, and so still there is a role of cardiac catheterization. One of them is that if you have a borderline case or you have a discrepancy between the clinical findings and the non-invasive findings. So as you see, there is a huge number of indications of cardiac catheterization in patients with. Even in acquired condition, this is a ruptured ventricular septum in patients with ventricular septal defect with an acute myocardial infarction. Here is the left ventricle posterior located, the right ventricle anterior located, and the shunt. Actually, we don't calculate the shunt in these conditions because we know these people are very sick. They have this considerable shunt. Even if the initial estimation is a low flow shunt, eventually the necrotic tissue will widen the ventricular septal defect and will create a significant shunt. But as you see here, you can still calculate the pulmonary pulmonary blood flow in relation to the systemic blood flow. Here you have the femoral artery, 93, minus 48 divided by 93 minus 79, so it will end up with a significant left to right shunt. Obviously, in patients with myocardial infarction, most of the patients have significant shunt, and we rarely do that. So we move from that to the pressure tracings, which we take in patients with stenotic valves. We know that there is a difference between the pressure tracing taken in the echo lab from the pressure tracing taken in the hemodynamic or the cardiac catheterization lab. Although we often take the mean pressure in both of them and they are equivalent, but in the cath lab we measure the peak to peak pressure, and this is an artificial pressure. The real pressure is the peak instantaneous pressure. So the peak instantaneous pressure is what we measure in the cath lab, in the echo lab, and the peak to peak pressure is what we measure in the cath lab. And usually, because of the difference, we substitute that for the mean pressure, which is equivalent in both. Look at patients with aortic stenosis, you get a slow rising pulse in contradistinction. With the hypertrophic cardiomyopathy, you get a rapid rise, which is almost parallel to the anacrotic limb of the left ventricular pressure waveform. Now, the aortic valve area and mitral valve area have been first measured using the Gorlin formula after Gorlin and Fort Gorlin, which was introduced by Richard Gorlin and his father, who was an engineer in 1951. The aortic valve area and the mitral valve area are both hydraulic formulas depending on the cardiac output divided by the heart rate, and in the case of the aortic valve, the systolic ejection period divided by a constant, which is 44.3 in the aortic valve and 37.7 in the mitral valve, multiplied by the square root of the pressure gradient across the corresponding valve. Actually, I don't think it's no longer important to remember this formula because we have a simple formula which is very applicable and almost as precise as the Gorlin formula. Both of them, of course, they have fallacies, and the Hack's formula applies equally well to the aortic valve area calculation and the mitral valve calculation. You just need the cardiac output and the mean gradient. Even if you don't have the mean gradient, if you have the peak-to-peak gradient or the peak instantaneous gradient, then it works. So a valve area for the aortic region, the cardiac output divided by the mean of any gradient, the square root of any gradient, and for the mitral valve area is the same. But the detailed equation is here for your interest. Now, we know that in patients, in the application of Gorlin's formula, it assumes the steady state and the fixed orifice. Both of them are not always available. It's not accurate with concomitant mitral regurgitation. It's not accurate in patients with extremely low cardiac output, and is not accurate at extremes of heart rate, very low or very high heart rate. So there are fallacies, and that's why substituting it by the Hack's formula is very well accepted. Now, if you look here for the aortic valve calculation, this is important to know. This is the aortic root measurements, and this is the left ventricular measurements, and this is the gradient. The way we get the mean gradient is that we planimeter this area. There is a little toy, it's called the planimeter. You just work with it on the edges of this white area, and it calculates for you this area. You divide it by the time which elapses from the point of intersection between the aortic pulse curve and the left ventricular pulse wave. So this is the time. This is the systolic ejection time. Systolic ejection time in this particular patient was 0.33 of a second. And this is the mean area. You divide the planimetered area or the measured area here by the time you get the mean gradient. So that's the way we were doing it previously in the cardiac cath. You rarely need to do that, but you have to know the idea, because in borderline cases and when there is discrepancy between the perception from clinical evaluation and the non-invasive findings, you ought to do that. So if you substitute the values, if you have a patient here with cardiac output of 5 liters per minute, heart rate of 74, systolic ejection time of 0.33, and mean and pressure gradient of 40, you substitute that and you get the area. So as you see here, there's a constant of 44.3 multiplied by the square root of the mean gradient, which is 40. Now, if you apply Hucke's formula utilizing only the cardiac output and the mean pressure gradient here, the square root of the mean pressure gradient, you get almost the same figure. This is 0.7, this is 0.8, very close to each other. And you just disregard. So in the examination, if you get all the figures, just ignore all of them except the mean pressure gradient and the cardiac output. Go ahead and calculate it by the Hucke's formula. It's very well accepted and very close to the findings that you can get with the Gordon's formula. Now, it's important to realize that in measuring the arterial pressure, you can measure it in the central aorta, here in pink color, and you can measure it in the peripheral arteries. As you go more peripheral, the arterial pulsation changes in two ways. It gets higher and it gets narrower. Remember that the radial pulse is distal to the femoral pulse. If you put your hand by your side, definitely the radial artery will be away from the heart, more away from the heart than the femoral pulsations. And that's why, if you look here in the yellow, I don't know what's this color, but this is yellow, orange. The orange color here is corresponding to the radial pulse, and the pink color here is corresponding to the aortic, and the green color is corresponding to the femoral pulse. The reason this is important is that frequently we put a cath in the left ventricle, and this will measure the left ventricular pressure, and we put the arterial pressure in the side arm of the sheath, whether the sheath is in the radial artery or in the femoral artery, and we measure the gradient. So remember, that's going to produce fallacies because of two reasons. Ideally, you should put the one cath in the left ventricle and the other cath is in the root of the aorta. You can do that by a double Young catheter, or you can put that by both are transfemoral retrograde catheterization, or the left ventricular cath can be a transseptal catheter and the other one transfemoral. But if you use the peripheral sheath, as is often done, you have to know that you are underestimating the gradient. You are underestimating the gradient because the peripheral pulsations is usually higher and the pressure value is usually higher. And look at the displacement. If you realign it with the ascending limb of the aortic pulsation, you underestimate the gradient. And if you measure at without realignment, you overestimate the gradient. So remember that if you are using left ventricular pressure against a peripherally recorded pressure, you have to be cognizant of these fallacies in estimating the gradient. Remember that we are using this in borderline cases, so you have to be as accurate as possible. Now, this is the situation in mitral stenosis. Again, the gradient here will be in diastole, is not going to be in systole. Again, the mean gradient is calculated by planimetry of this area, which is here in white, and you calculate the diastolic time period between the intersection of the isovolumic relaxation period in the left ventricle and the beginning of systole in the next cycle. So you divide the area calculated by the estimated by the planimeter divided by the time interval here, and this time interval is used as the diastolic flow period. So if you have the cardiac output, heart rate, the diastolic blood filling period, then you can plug these values into the Gordon's formula, and you end up with the reading. But again, you can use the Hucke's formula, dividing the cardiac output here by the square root of the gradient across the mitral valve, and you come up with a close figure corresponding to the Gordon's formula estimation. The Gordon's application to the pulmonary valve and the tricuspid valve has not been validated so far, and so we depend on gradient. Even for everyday work, we depend on gradient. So if I tell you that this patient has a gradient of more than 10 millimeters of mercury, in this patient is 25 millimeters of mercury at a heart rate of 70, so a relatively slow heart rate. This is significant mitral stenosis. You don't need to calculate the areas and you go into this hassle. So But it's again, sometimes you have to resort to that if you get marked discrepancy between your estimation clinically and your findings by the non-invasive methods. So that's the main indication in doing cardiac cath in these patients. Now, this is another question. A 27-year-old man presenting with dizziness and a systolic murmur, and this is the pressure gradient in the femoral artery versus that on the left ventricle. If you look into here, what is the lesion? Is it aortic valve stenosis, or it's hypertrophic cardiomyopathy, mitral regurg, VSD, or subaortic discrete membrane? Now, the answer here is hypertrophic cardiomyopathy. And why is that? If you look into the pressure tracing here in the aorta and the left ventricle, there is no gradient. There is no gradient. So you cannot have no gradient in patients with valvular aortic stenosis. There is always a gradient, whatever the location of the catheter in the left ventricle. You can get it in subaortic membrane if you are locating your catheter, the tip of your catheter distal to the membrane. So there is no gradient. The gradient will be across the membrane. But look at what happened here. There is a ventricular premature beat, and after the ventricular premature beats, two things happen. There is an increase in the gradient or generation of a significant gradient. But the more important thing is that the pulse wave became less prominent. So even in aortic stenosis, after a premature beat, after a ventricular premature beat, you will get an exaggeration of the gradient. But as I will show you, the pulse wave in valvular aortic stenosis will increase. So in hypertrophic cardiomyopathy, you get two changes. Number one, there is more filling in the post-extrasystolic period, so expected that the pulse wave will not decrease, will increase. But at the same time, there is a regeneration of calcium here, and there is regeneration of calcium here, and this calcium is added together prematurely, and this produces much more contractility in the outflow tract of the left ventricle, so the cardiac output actually decreases, and this is illustrated by a decrease in the pulse volume. So it's the important point here is not the generation or the exaggeration of the gradient between the left ventricle and the aorta, but it is the decrease in the pulse volume in the post-extrasystolic beat. This is the famous Brownwald sign, and it's very clear in this condition. This is a patient with hypertrophic cardiomyopathy, no gradient between the left ventricle because the catheter and the aorta because the catheter was located distal to the side of the SAM or the site of the obstruction. And look at the pulse wave before the PVC. This is considerable pulse wave. Now, after the PVC, you get a diminution of the pulse wave. So broken bro sign is not an increase in the gradient because that occurs in valvular aortic stenosis, and I will show you that very soon. But it tells you it denotes the decrease in the pulse volume. Actually, you can get other changes in addition to decrease in the pulse volume, and that's the appearance of the spike and wave. Spike and wave appearance of the wave, which is or the dome and the dart or the bacterian curve, which are synonyms for the specific pulse wave of hypertrophic cardiomyopathy. So if you look again into this wave, you'll see it's the wave not of valvular aortic stenosis. Look at the ascending limb, it's sharp and it's almost parallel to the anacrotic limb of the ventricular pulse wave. And this is in contradistinction to the situation of valvular aortic stenosis, where you get a delayed appearance of the pulse wave. So the ascending limb will be oblique like that, and I will show you an example of that. So actually, broken bro sign indicates three things. Number one, you get a typical pulse wave here in the ascending limb. You might get a bacterian curve, or you might, which is again called a spike and a dome, or a dome and a dart. Another positive wave before the dicrotic notch, but the most important thing is a decrease in the pulse pressure in the post-PVC beat. Now, this is a situation of our valvular aortic stenosis. As you see, wherever you are with the left ventricular catheter, there is always a gradient between the left ventricle and the aorta. Left ventricle here is in yellow, aorta is in green. And after a PVC, you get an exaggeration of the gradient. But look at the pulse wave, it's exaggerated. Now, during valvular aortic stenosis, after the PVC, there is a post-PVC period, which is a compensatory period, during which the left ventricle fills more, ejects more, creates more gradient, and creates more pulse pressure. So this is a situation that's completely different from the situation in hypertrophic cardiomyopathy. So to summarize this situation, the differences between aortic stenosis and hypertrophic cardiomyopathy, if you decrease the venous return by Valsalva maneuver, then the gradient will decrease in valvular aortic stenosis, but the decrease in the venous return will collapse the left ventricle, will exaggerate the SAM contact, and will result in increase in the gradient, which is different from valvular aortic stenosis. But in both conditions, because of the decrease in the venous return, the pulse pressure will decrease. And after a PVC, because of the increased filling of the left ventricle, increased ejection through the stenotic valve, there is an increase in the gradient here. And the same finding is present in hypertrophic cardiomyopathy. But it is the pulse pressure which makes the difference. So the pulse pressure increases, as I showed you in the last slide, in valvular aortic stenosis, and will decrease, illustrating the Brocken-Brough phenomenon, which was described by Brocken-Brough, Bronwald, and Morrow, which was the surgeon associated with them at that time. Now, this is what happens during Valsalva maneuver in a patient with hypertrophic cardiomyopathy. As you see in the basal state, there is no gradient at all because the catheter was located here in an area beyond the obstruction. But look what happened when during the straining phase of Valsalva, there is a decrease in the venous return, collapse of the left ventricle, and the gradient has been generated. And this is very well illustrated here and pointed out in the previous table. In a patient with hypertrophic cardiomyopathy, as you pull from the inlet of the left ventricle up to the aorta, there is a gradient here proximal to the site of the obstruction. As you move beyond the obstruction, the aortic pressure will be equivalent to the left ventricular pressure. You are still here in the left ventricular cavity. As you see here, this is a left ventricular cavity. There is no gradient because you are distal to the obstruction. And then as you go through the aortic valve, there is no gradient, obviously. So the gradient is essentially proximal to the obstruction, but you have three parts of the picture. You have left ventricle proximal to the obstruction against the aorta. You have left ventricle distal to the obstruction and the aorta, and you have left ventricle beyond the aortic valve. So it's the aorta against the aorta, and there is no gradient. So the factors which increase the left ventricular outflow tract in patients with hypertrophic cardiomyopathy is obviously known to every one of you. Increase in contractility, like giving the patient any positive inotropic agent, increasing the preload like standing, decreasing the afterload like giving the patient nitroglycerin, or can lower the gradient by diminishing the contractility with beta blocker or calcium antagonists, increasing the preload by fluid infusion, or increasing by afterload classically by neosynephrine or phenylephrine. Now, simple question here is that a 59-year-old female presenting with shortness of breath. Look at this diagram. This is the right atrium here. This is the right ventricle against the pulmonary artery. Which of these is the typical abnormality? RVD, ASD, pulmonary stenosis, pulmonary hypertension, tricuspid regurg. If you look into the right atrium, there is a very prominent A wave, and there's a slightly attenuated V wave. There is marked gradient between the pulmonary artery pressure and the right ventricular pressure. So obviously C, very simple, C is the appropriate explanation. What is the valve lesion, which is denoted by this pulse wave form? This is a femoral artery pulse wave form. If you look into this, this is the typical Corrigan's pulse of aortic regurg. Can also be encountered in patients with arteriovenous fistula. Sometimes you get a patient on hemodialysis with a significant arteriovenous fistula. If you find this picture, then you realize that the arteriovenous fistula is overburdening the heart to some degree. There is no, as you see, because of the peripheral vasodilatation in these patients, the dicrotic notch is down here. Sometimes it's down here because this is an elderly individual and you don't get a recoil from the aorta. So looking at the pulse pressure, you can get much more information than just calculating the pulse pressure. Now we move to calculating the regurgitant fraction. This is an example of mitral regurg. If you have the left ventricular ejection, it goes into both directions, the forward direction, which is the systemic blood flow, and the backward direction, which is the mitral regurgitation flow. So the total left ventricular volume will be equivalent to the summation of the systolic forward flow plus the regurgitant flow. In other words, if you wanted to know the regurgitant volume, you subtract the systolic forward flow from the total left ventricular flow. You can estimate this by the difference between the end diastolic volume and the end systolic volume, and you can measure the systolic flow by fixed principle or thermodilution, although it's not to be welcome in patients with valvular disease. If you divide the regurgitant volume by the total left ventricular volume, you get the regurgitant fraction. Regurgitant volume more than 60, regurgitant fraction more than 50% for the mitral, as well as the aortic, signifies a significant regurgitant lesion. So this is the calculations, easy. If you get a left ventriculogram, you can calculate the total stroke volume of the left ventricle. The left ventricular end diastolic minus the left ventricular systolic volume. If you wanted the forward stroke volume, you use fixed principle. And if you wanted to calculate the regurgitant volume, you subtract the forward stroke volume from the total stroke volume, estimated as above here. And if you want to calculate the regurgitant fraction, you divide the regurgitant volume, not stroke volume, regurgitant volume by the total stroke volume. So this satisfies the requirements of the guidelines. Another question, a 70-year-old man with mitral regurg, he had a left ventriculogram, and diastolic volume 120 and systolic volume 30, cardiac output 6 liters per minute, heart rate is 100 beats per minute. How much mitral regurgitation is there? Is it severe? Is it moderate? Is it mild? So we look into the calculation. Remember these figures. The total volume will be the end diastolic volume minus the end systolic volume. End diastolic volume was 120, end systolic volume 30. So the total stroke volume of the left ventricle is 90. Part of it is going forward, part of it is going back to the left atrium. How can we know the forward? Fixed cardiac output measurements. You have the cardiac output 6 liters divided by the heart rate. So 60, so the difference between 60 and 90 is the regurgitant volume divided by the total left ventricular volume, and you end up with the regurgitant fraction of 33. So 33 is a moderate mitral regurg. We know that to be severe, it should be 50%. To be mild, it should be less than 20%. So this is a moderate mitral regurg. Now we have a full circle back in our curriculum, going back to the lecture on heart failure. You remember the pressure volume loop. So we, in order to finalize these things, we go very rapidly across the pressure volume loop. You remember that we explained it in details in the curriculum for heart failure. And as you see, the pressure volume loop here lives between two lines, the end systolic pressure volume relationship, which is a linear relationship between end systole for different cardiac cycles and the end diastolic pressure volume relationship. So if you start from the lower rightward corner, here is the mitral valve closure, isovolumic contraction period. Here is the aortic valve opening. You get the ejection. It ends at the line which is a surrogate of cardiac contractility. The aortic valve closes here, and then you get the isovolumic relaxation period. The mitral valve opens here, and you get filling of the ventricle. Remember, the distance between the isovolumic relaxation and isovolumic contraction is the stroke volume. So the wider the loop, the larger the stroke volume, and the area of the loop is the stroke work. The stroke work is the stroke volume multiplied by the mean arterial pressure. So this is the fundamental thing of the loop, and we explain that in extreme details in the curriculum for heart failure. So what happens in systolic dysfunction, the ESPVR, or the end systolic pressure volume relationship, moves down and to the right. And by moving down and to the right, you can see what happens here. The stroke volume instead of being that large, shrunk to become that small. So with systolic dysfunction, the ESPVR, end systolic pressure volume relationship, moves down and to the right, and the stroke volume gets actually in most patients, not all patients, but most patients, we know that there is now many articles saying that diastolic dysfunction is not by necessity a part of systolic dysfunction, as we previously know, but in the majority of patients with systolic dysfunction, we also get diastolic dysfunctions. What diastolic dysfunction creates? It creates the relation between the volume and the pressure, which is a curvilinear relationship. Here moves up and to the left. So systolic dysfunction down and to the right of the ESPVR, and the diastolic dysfunction is up and to the left. So as a result of that, the cardiac work decreases, although the stroke volume might not be affected tremendously. But very often you get a combination of these conditions. So this is a condition in which there is a decrease in systolic function. The ESPVR moves down and to the right, and there is also a concomitant diastolic dysfunction. The diastolic pressure volume relationship moves up and to the left, and as a result of that, the stroke work decreases, and the stroke volume, instead of being that wide, it becomes shorter than that. Obviously, the opposite will occur if you have any line of treatment which improves this condition. So if you have an afterload reduction, like giving sodium nitroprusside, which is a balanced vasodilator, it decreases the systolic blood pressure. So you get the point of end ejection will move in this direction. As a result of that, the stroke volume will increase, and at the same time, the pressure volume relationship in diastole will decrease. As a result of that, you will get a decrease in the pressure at any specific volume. So sodium nitroprusside improves the diastolic functions, improves the systolic functions, and that's the way they act as we previously had. If you get an inotropic therapy, particularly if it's an inodilator, like milrinone, to a lesser extent the glutamine is going to increase the surrogate of contractility, which is in ESPVR, upward and to the left, and as a result of that, the ejection will continue to the green line. So as you see, the stroke volume increases. Instead of being that wide, it becomes wider. And at the same time, if it has a peripheral vasodilator effect, it improves the diastolic function, and you get an improvement in the diastolic function as well. This is more prominent with milrinone than with the glutamine. So we jump these things because this is very preliminary to you, and we come to the last thing in this presentation, which is the FFR. Now, the idea of the FFR is we wanted to measure what is distal to the obstruction in the coronary arteries, and this is usually what we are measuring is not the pressure, but the volume. But in order to get the volume represented faithfully by the pressure measurements, which is easier, you have to vasodilate the peripheral coronary circulation. So at maximum peripheral hyperemia, the distal pressure, distal to the obstruction or the stenosis, divided by the proximal pressure is the fractional flow reserve. So we measure here by a guide wire with a tip transducer proximal to the tip, the pressure proximal here, and the pressure at the guide catheter, which is the proximal part of the coronary artery or in the aorta itself. and we divide the distal measured pressure by the proximal measured pressure. Actually, we are not measuring the pressure, we are measuring the volume, because these pressures are taken at maximum hyperemia, and if you drop the resistance down to almost zero and make it stable, then the pressure can be a faithful surrogate for the volume. So you wait for some time after giving adenosine or ligadenosine to these patients until the pressure becomes stable, not during the divergent point. And as you see here, this is the proximal pressure, proximal to the lesion, and this is the distal pressure, and the difference here is 0.71. And we know that the cutoff point is 0.8, so anything above 0.8 you can defer dilatation of this vessel, no intervention, even up to 5 years. Anything below 0.8 will be a candidate for dilatation or intervention, and the ideal intervention should achieve a 0.9. So if you get a patient with an unknown degree of stenosis, like this, for example, then you can see that this is the proximal pressure, this is the distal pressure to the stenosis. The FFR measured is 0.71. This is below 0.8, so it's significant. Something should be done about it. Because the vasodilatation is cumbersome and is associated with side effects including pain, heart block, hypotension, flushing, so forth, then the IFR was created, the instantaneous wave-free ratio. This waveform is representative of what happened in the coronary circulation in diastole. A part of diastole here, you will find that the pressure proximal and distal to the stenosis is constant, is stable, and is approaching almost zero pressure. So this part of diastole is very applicable for utilization without the need of giving peripheral vasodilatation. So there is no adenosine, there is no papaverine, there is no nothing. You just measure it in the difference between the pressure distal and the pressure proximal during this period, and the cutoff point here is 0.89. So after the introduction of this, there was some controversy about its validity, but in the Sweetheart trial, you can see that the outcome, this is the outcome, this is not the difference between them. The outcome over 1 year was completely similar to our. So the occurrence of myocardial infarction, occurrence of heart failure, and the need for urgent revascularization was the same, whether you are using the IFR or the FFR. So because IFR is more comfortable and less cumbersome, so it has almost replaced the IFR. Since that, there are other indices that have been introduced, like the resting full diastolic ratio and other ratios, which can be utilized in this area, but the most commonly used now is IFR. Many centers or many cath lab are using both, but that creates unnecessary confusion. So if you are using the IFR, the cutoff point is 0.89, and if you are using the FFR, the cutoff point is 0.8. Anything above that, you can defer dilatation. Actually, you might do harm, because any procedure is associated with complication. So you avoid the complications if you don't do it. And you have a warranty period in the large majority of cases up to 5 years. But if you have a lesion which produces an IFR less than 0.89 or less than 0.8 in FFR, then you ought to intervene on these patients. Now, there are some exceptions. It's applied to almost every vessel, but you cannot apply this to venous graft or patients with heart failure or patients during the acute setting of myocardial infarction in the culprit vessel. So apart from these three conditions, culprit vessel and acute myocardial infarction, you can use it in the non-culprit vessel. In the culprit vessel, you can use it because the peripheral circulation is unstable for the first 5 days, and as a result of that, you cannot equate the pressure with the volume. So you undermine the whole concept of the equation. At the same time, in patients with heart failure, the right atrial pressure is high, so you cannot say that the right atrial pressure is 0. This is an integral part of the equation. And in patients with saphenous vein graft, the lesion is rapidly progressive. So you cannot guarantee that if you defer, you get this 5-year warranty period. So apart from these three conditions, you can apply FFR or IFR equally effectively and very fruitfully in prediction which lesion is going to be dilated and results in an optimal outcome. So with this, I think we finished this curriculum and we get the questions. And by this, you finished listening to almost 1,500 slides. And I thank everybody that has been patient to relate this amount of presentation. We answered almost 200 questions. And I hope to get a question this night before closing this. محمد بيه.
أول سؤال جه بيسأل كان FFR be used.
أنا متوقع أسئلة كتير. اتفضل.
أول سؤال بيسأل can FFR be used in avolemic heart failure?
Heart failure with treatment? The idea إنك get the right ventricular atrial pressure down to 8. Because عشان نحول البريشر إلى فوليومز احنا فارضين ان الرايت اتريال بريشر نورمال او 0. لكن لو رايت اتريال بريشر 16 مش هتقدر تقول ان 16 تبقى 0. You have to make other measurements. So we don't use the FFR. Usually we don't take the patient with severe heart failure إلى الكاردياك كاث إلا في البرايمري. إنما ما عدا ذلك we usually settle the patient إذا كان عنده heart failure we treat him and then we use the FFR in the cath lab إذا كانت أو متوفرة في الكاث لاب.
اوكي سؤال بيسأل can FFR be used in left main lesions؟
إنك أنت تستخدمه في الليفت مين ليجن you have to measure LAD and circumference at the same time. If you have the LAD في lesion then it means that the territory اللي هو بيبقى فيها الفلو بقت compromised لأنه LAD مسدود. سواء مسدود completely أو مسدود partly. وبالتالي الاريا دي هي اللي بتحدد قد ايه blood flow بيحصل. فانت ما بقتش في good relation between the pressure and the volume. So if you get from the LAD to the left main lesion, then you have to find out if it is significant, should be diluted before coming to the conclusion that the left main lesion is significant. Same to the circumference. You can use it in the left main, you can use it in the LAD, the right coronary, the left coronary, circumference, anything. Under any circumstances except the 3 conditions اللي أنا قلت عليهم.
اوكي وفي سؤال بيسأل في حاجة حضرتك شرحتها بيسأل why ال IFR and FFR cannot be applied to venous grafts.
لا هو الفكرة في الفينوس جرافت إن البروجريشن اوف ذا ليجن ما يديش الجارانتي. You can use it of course. لكن you cannot say انها هيديفير لمده قد ايه. ما هم احنا لو كنا هنديفير لمده شهر وشهرين والعيان يجي تاني نعمل له الدايليتيشن ولا الستنتنج ما عملناش حاجه. انما هي الاستادي ورت ان السيف از ا بوبيوليشن ستادي. طبعا ممكن تاني يوم العيان يجي له مايوكارديال انفاركشن لانه كان عنده سبستراكتيف ليجن بس ده رابشر. لكن as a population study you can safely defer for a long period. The studies were at 5 years is all.
سؤال بيسأل can CMR replace right heart case for estimation of shunt fraction؟
كل الحاجات اللي الايكو كان measure the shunt fraction. ال CMR can measure the shunt fraction. The CT can do the same thing. But the problem is انك انت في الثلاثه دول هم which are the non-invasive methods available to us. You assume انه الاوتفلو tract of the right ventricle, left ventricle are circular. The left ventricular outflow tract is semicircular, and the right ventricular outflow tract is anything but circular. وبالتالي انك انت تميجر الاريا is imprecise. You can measure the VTI easily, but you cannot measure الاريا. انت متوقف على انك انت بتميجر الاريا وتضربها في الفي تي اي. سو الميجر الاريا ما هياش سيركولار، وبالتالي ما تقدرش تقول انها ار باي سكوير اللي هي الاريا. فده هو الاشكال في الميجرمنت ده. لكن the guidelines is simplifying the situation. If you have an ASD with right atrium and or right ventricular dilatation, that's a significant shunt. If you have a VSD with left atrium, left ventricular dilatation, that's a significant shunt. Same applies to patient ductus arteriosus. If you are hesitant, if you don't know how to measure the volumes, if the volume come into borderline, if the patient is highly symptomatic and the shunt calculated by non-invasive methods is not that much, there is a discrepancy, then you ought to go to the cardiac catheterization. If you are not sure what's happening to the pulmonary vascular resistance, if you wanted to use a vasodilator test to the pulmonary resistance, then all of these are indications for cardiac catheterization. So cardiac catheterization still has a place. Remember, cardiology is hemodynamics. يعني even if you are thinking of echo or CT or MRI, we are thinking in terms of hemodynamics. هو الاختلاف بين الكارديولوجي وبقيه برانشز الميديسن مفيش للبرين ولا للليفر ولا للكدني هيموداينامكس، او الهيموداينامكس is very simple or unknown, but the cardiology is hemodynamics. So you have to have a solid. This is not detailed hemodynamics. احنا كان عندنا كلام كتير قوي عن الهيموداينامكس but because we are on daily basis we can see most of this information. But you have to know that, particularly cardiac output.
السؤال بيسأل during measuring the pressure gradient, can we apply ball back or we must calculate the pressure gradient with simultaneous pressures?
It depends. If you are in a high pressure system زي مثلا انك انت بتقيس البريشر across the aortic valve, the pressure gradient will be high. وبالتالي a pullback will be satisfactory provided that you are using a catheter with end hole, not side holes. ما هياش big tail catheter جزء منها في قلب الليفت ventricle جزء منها في قلب الأورطة. So it's valid. But if you are studying the tricuspid valve is significant gradient is 5 millimeter of mercury. So that's a small number. A significant gradient في الأورطة is 40 millimeters of mercury. A significant gradient في mitral is 10 millimeters of mercury. A significant gradient في aortic coarctation is 20 millimeters of mercury. A significant gradient في subaortic membrane is 30 millimeters of mercury. If you are coming across a tricuspid valve with a small gradient, then you ought to have two catheters or a catheter with double lumen in order to get simultaneous pressure measurements. But if you are in a high pressure circulation, for example, severe pulmonary stenosis, left ventricular pressure will be systemic. So that's a significant gradient. You don't need in fact to get two catheters or double lumen catheter. So it depends. And the tricuspid valve, definitely. Particularly if you want to know the effect of intervention, like taking a deep breath or something like that.
اوكي مفيش أسئلة تاني.
Okay, so we thank everybody attended this series of lectures. We have been working من شهر يوليو أو حاجة زي كده، يمكن قبل يوليو. We thank الدكتور محمد عبد الغني وصاحب الايديا. We thank الدكتورة وفاء العروسي.
يا بيه الشكر كله لحضرتك، ربنا يبارك
كتر خيرك يا ست الكل.
يجازيك عنا كل خير.
الدكتورة وفاء العروسي ما فيش شك. We thank محمد الدكتور ياسر بغدادي لانه هو ساعدنا في الاول وهيساعدنا في ان احنا نلم السلايدز دي. محمد ثابت has been always
محمد عمل مجهود رائع كمان يا دكتور محمد الحقيقه.
محمد ثابت for several years. We have been doing that now for almost 15 أو أكثر من 15 years. محمد ثابت participating في last 3-4 years. أحمد شحاتة يفوق كل الناس كلها، هو has been with me for several years. The important point إن إحنا من خلال الدكتور ياسر بغدادي ومن خلال الدكتور محمد ثابت هنلم الحاجات دي كلها وهنحطها على جوجل درايف and will be accessible to anyone that wants to revise the contents بتاع this lecture. Thank you very much and I hope to see you later in a better situation. I hope in the lectures today will be helpful to you for examinations and more important for your practice. السلام عليكم ورحمة الله.
وعليكم السلام ورحمة الله. شكرا.
وعليكم السلام ورحمة الله. شكرا دكتور محمد.